Hello, everyone, and welcome to the MediByte channel. As a healthcare professional here at MediByte, I am absolutely fascinated by how clinical teams handle intense, high-stakes situations. Today, we're diving into a crucial explainer, taking a close look at how complex medical science translates into rapid, life-saving care on the delivery floor. You know, the vast majority of childbirths are incredibly smooth and, thankfully, pretty predictable. But what exactly happens when delivery doesn't go as planned? Today, we're going to explore two rare but absolutely critical emergencies that require highly specialized, rapid care. These are those pulse-pounding moments where clinical protocols and flawless teamwork literally save lives. So here's our roadmap for today's explainer. First, we'll cover what is shoulder dystocia, jump right into the risks and complications, and see exactly how medical teams go about resolving the emergency. After that, we'll shift gears to amniotic fluid embolisms and wrap up with emergency embolism treatments. Let's kick things off with Section 1. What is shoulder dystocia? Specifically, the mechanical obstruction. Okay, so what exactly are we talking about here? Well, shoulder dystocia is a serious complication where one shoulder of the fetus literally lodges right against the pregnant woman's pubic bone or sacrum. Think of it as a purely physical roadblock. The head of the fetus actually delivers successfully, but the baby gets physically caught in the birth canal because that shoulder is stuck. Because of this tension, you'll sometimes see the baby's head actually pull back slightly into the vagina. And here is exactly how this escalates into a full-blown clinical emergency. Step 1, the fetal head delivers. Step 2, that shoulder lodges against the bone. Now, Step 3 is where the danger really spikes. The birth canal puts intense squeezing pressure on the baby's chest and the umbilical cord. Because of this compression, the baby simply can't breathe, which, as you can probably guess, leads directly to Step 4, a rapid, dangerous drop in the baby's blood oxygen levels. It's a terrifying mechanical failure, right? But understanding this exact sequence is absolutely crucial for medical teams to act quickly and prevent serious injury. Moving on to Section 2, risks and complications, or basically recognizing the danger before it happens. So while shoulder dystocia isn't exactly common, there are certain variables that significantly increase the odds of it happening. A very large fetus is the most obvious one. It directly contributes to that mechanical mismatch we just talked about. And notice maternal diabetes on this list? That's really interesting because it often leads to a larger than average fetus. Other red flags included difficult, prolonged, or even an unusually rapid labor, maternal obesity, or having had a prior delivery with shoulder dystocia. It's also way more likely if the delivery is assisted by a vacuum device or forceps, specifically because the fetus's head hasn't fully maneuvered down into the pelvis yet. Now, we really have to remember this is a dual patient emergency. We're treating two people at once. For the fetus, the risks include broken bones during the delivery itself and a really high risk of injury to the brachial plexus. That's the vital nerve network connecting the spinal cord to the shoulders, arms, and hands. On the flip side, the maternal risks are just as severe. We're talking excessive postpartum hemorrhage, massive muscle tears in the genital area, nerve injuries in the groin, and get this, even the physical separation of the pubic bones. It's incredibly traumatizing for both patients. Which brings us to Section 3, resolving the emergency through targeted medical interventions. When shoulder dystocia hits, doctors have to act at lightning speed, using a very specific step-by-step protocol. First, they'll try a series of physical maneuvers to manually free that shoulder for a vaginal delivery. Step 2, if needed, they might perform an episiotomy, making a surgical incision to widen the vaginal opening. But what if those physical techniques just aren't working? Well, the clinical protocol dictates a dramatic shift for Step 3. The baby might actually be pushed back into the vagina. I know, it sounds super counterintuitive, but it leads directly to Step 4, an immediate emergency cesarean delivery. It is a rapid, highly structured response perfectly designed to save both lives. Okay, let's shift gears to Section 4, amniotic fluid embolisms and the systemic reaction they cause. Unlike the mechanical issue we just covered, an amniotic fluid embolism is a life-threatening systemic reaction. It happens when amniotic fluid, which contains fetal cells and tissue, somehow enters the pregnant woman's bloodstream. I really want to emphasize here, this is exceedingly rare. It typically pops up during late pregnancy, though it can happen earlier. But, and this is a big but, while it is rare, it remains one of the absolute most likely causes of sudden maternal death during labor. So what exactly opens the door for this fluid to breach the maternal bloodstream? The risk factors are actually pretty extensive. They include older maternal age, carrying multiple fetuses like twins or triplets, or having an excess amount of amniotic fluid, which is known clinically as polyhydramnios. Significant risks also stem from placenta issues, whether it's positioned wrong, attached abnormally firmly to the uterus, or detaches way too soon. Other major triggers include eclampsia, induced labor using medications, abdominal injuries, a torn cervix, uterine rupture, or even a routine cesarean delivery. Basically, any sort of structural disruption to those boundaries increases the risk. The terrifying thing about this condition is its incredibly fast systemic timeline. It acts almost like a catastrophic allergic reaction. First, the fluid or tissue breaches the bloodstream during or right after labor. This immediately triggers a rapid heart rate, plummeting blood pressure, and severe difficulty breathing, which can escalate into full respiratory failure or sudden cardiac arrest in literally minutes. Then, a devastating complication called disseminated intravascular coagulation, or DIC, sets in. This means tiny blood clots develop throughout the entire bloodstream. Paradoxically, this uses up all of the body's clotting factors, resulting in massive, widespread, and uncontrolled bleeding. That brings us to Section 5, emergency embolism treatments, and the multi-pronged response required. Because this timeline moves so incredibly fast, prompt diagnosis is almost entirely clinical and symptom-based. Doctors simply do not have time to sit around waiting for a long panel of lab results to come back. They have to diagnose this on the fly based on the sudden onset of these hypercritical symptoms. The sudden stopping of the heart, immediate severe breathing issues, crashing blood pressure, and that widespread uncontrolled bleeding we just talked about. Sometimes they might utilize rapid blood tests specifically to check the function of blood-clotting proteins just to confirm the DIC, but speed is absolutely everything here. Tackling this kind of life-threatening emergency requires a coordinated team of specialists armed with intensive care tools. First step, they immediately provide CPR and breathing assistance, alongside medications just to get the heart contracting again. To fight that massive blood loss, they push rapid transfusions of blood and vital clotting factors, and honestly, this step alone is often what saves the patient's life. They'll also administer meds to forcefully induce uterine contractions, which helps clamp down on further bleeding. Finally, if CPR doesn't resolve the cardiac arrest, the baby has to be delivered right then and there. This emergency delivery, whether it's done via forceps, vacuum, or C-section, can be the critical turning point for the woman's survival and absolutely life-saving for the fetus if they're old enough to survive outside the uterus. So what is the big takeaway from all of this? Well, while both shoulder dystocia and amniotic fluid embolisms carry incredibly high risks, modern medicine is remarkably prepared. Specialized intensive care teams and rigorous, well-rehearsed clinical protocols are designed specifically to resolve these exact crises. Honestly, it's a profound testament to the resilience of the human body and the sheer expertise of emergency medical teams who step up exactly when seconds count. Thank you so much for learning with us here at MediByte today. I really hope this explainer gave you a much clearer understanding of these complex childbirth emergencies. It kind of leaves you wondering, right? As medical technology and predictive AI continue to advance, will we one day be able to perfectly predict and entirely prevent these mechanical mismatches before labor even begins? That would be a real game changer. If you found this information valuable, please like, share, and definitely subscribe to the MediByte channel so you never miss out on our future clinical explainers. Keep learning, stay curious, and we'll see you next time.